this is a lecture that would be very difficult to cover in just 1 hour, so we're going to try to go through most of the pathologies in a way that you guys understand it, because it's really geared for the residents before anything else. If we don't finish, maybe we can get an extra slot some other time. If it goes too slow, just let me know and I will go much faster. What I will cover today, hopefully, are the central serous chorioretinopathy, the pathologies that are related to the vitreoretinal interface abnormalities, that is, the vitreomacular tractions and epiretinal membranes and macular holes. Very briefly, I'll go over the post-surgical macular edema, which you guys know as the Irvine-Bell syndrome. Then we will talk about juxtafoveal telangiectasia, and if we have time, we'll talk about photodynamic therapy. I will exclude choroidal neovascular membranes, which here I'm going to talk to you about in about 2 weeks. You're going to have a full hour on just CNB. Also will be included the traumatic maculopathies. For those who are attending the basic science course, that will be covered during the basic science course. Macular dystrophies is a completely different thing. This will require several hours of lecture, so those will not be included. And inflammatory conditions and tumors will not be included as well. So let's start with central serous chorioretinopathy. The term central serous chorioretinopathy was coined by Dr. Daniel Ross in 1967. And he used this term to describe what is an idiopathic, circumscribed serous detachment of the neurosensory retina from the RPE. Generally, this occurs in healthy individuals, most likely males and females, and the age spectrum, the age range that this pathology occurs within is between 20 to 50 years. It often happens in people who are either emmetropes or hyperopes. Therefore, people with thin cornea, such as myopes, this is much less likely, and it is uncommon in blacks. By definition, the central serous chorioretinopathy is idiopathic, but we know that there are several forms of CSR that can be related to a specific cause, such as pregnancy and acute hypertension, end-stage renal disease, organ transplantation, and the use of even sometimes the use of steroids very such as in creams and ointments and inhalers, which can, in some predisposed individuals, cause central serous response. What we know now is that for sure central serous chorioretinopathy is due to a choroidal hyperpermeability, which is easily visible on Indocyanine Angiography. And we know that it's caused by choroidal thickness with choroidal hyperpermeability, with a concomitant alteration in the RPE barrier function, and at the same time a deficiency in the pumping mechanism of the RPE. CSR is usually asymptomatic unless the central detachment occurs near the fovea. And at that time, people can complain of any disturbance in central vision. It could be micropsia, which is like seeing things a little smaller than usual, or blurring of the central vision, metamorphopsia, that is the undulation, seeing things that are not completely straight, central scotomas, and in some cases people just realize that they just need more glasses, more reading glasses, and it can be corrected with increasing hyperopic correction. Central serous chorioretinopathy is a spectrum. It is not just the presence of fluid between the RPE and the macula. It is a spectrum of pathologies that are related to this hyperpermeability and that can translate in things in addition to the neurosensory retinal detachment, or signs that can happen or can occur and which you can see in the absence of a neurosensory retinal detachment. And those are these which we're going to talk about in a moment. So classically, the presence of central serous chorioretinopathy is really a neurosensory retinal detachment, a detachment of the neurosensory retina from the retinal pigment epithelium. It is usually one single bleb that is round or oval. It's usually well delineated. If it's relatively acute, then usually the fluid is pretty much transparent. If it has been there for a long time, it can be accompanied by a yellowishness of the fluid or the presence of a little bit of precipitates at the back surface of the retina. And in certain cases, if this is chronic, it can also translate into the retina by some leakage inside the retina, and that is like a CME response. Here on OCT, you can clearly see that there is a hyporeflective area which delineates the detachment of the neurosensory retina. This would be the photoreceptor layer, and this is the RPE right there. The neurosensory retinal detachment is due to a focal leak at the level of the retinal pigment epithelium, which can be very clearly seen on a fluorescein angiogram. It translates as a hyperfluorescent dot at the level of the retinal pigment epithelium. And as you go along in the fluorescein angiogram, you will have progressive dye leakage and pooling, that is sequestration of the dye with the fluid inside this pocket of fluid. Most of the time you have just one spot that leaks. In some cases, about 20% of cases, you can have several spots that leak. And most of the time, these spots are within one disc area from the foveal center. Sometimes they're away from the foveal center, much more, distant from the foveal center. And in certain cases, they can also be extramacular and kind of bringing in fluid towards the macula by gravity. There are classically two types of focal spots that leak. The classic one is a smokestack, but the ink blot is by far much more common. This is a little this is the early angiogram. This is the venous phase of the angiogram, and then later on, with the recirculation, you can see that there is a hyperfluorescent dot here, which should not exist, and this dot becomes more hyperfluorescent and starts to have a little bit of a fuzzy edge, and the fuzziness increases in size and in fuzziness. This is a classic ink blot pattern of leakage. In some cases, you have a smokestack pattern, and that is you have a little dot, and this dot becomes hyperfluorescent, and the fluorescence, the hyperfluorescence kind of goes upwards like an umbrella, exactly like an umbrella, basically, and the dye with the fluid goes up and then basically comes down to fill this pocket of subretinal fluid. This is a central leak, I guess you know this. Now, you can also have extramacular leak. If you notice here, this is a fluorescein angiogram relatively early, and you have a hyperfluorescent dot right there, but also here, and later on the angiogram, this hyperfluorescent dot has increased in size, and it is also fuzzy. This also has increased slightly in size, and it's also fuzzy, and it is contributing to the neurosensory retinal detachment, which is here. Here you have RPE changes here that are due to this leakage, chronic leakage. So, in addition to the neurosensory retinal detachment, you can have pigment epithelial detachment. We talked about the pigment epithelial choriocapillaries relationship yesterday, and we said very well that it is difficult for the RPE to detach itself from the choriocapillaries because of the presence of the Brooks membrane, okay, which consolidates this worm attachment. But you can, in some cases, have a localized, very limited pigment epithelial separation from the retinal pigment, from the choriocapillaries. And in this case, you have a pigment epithelial detachment, and this will manifest itself as a round lesion, usually orange. Most of the time we see it as an orange lesion with a very well delineated, distinct rim. And on the fluorescein angiogram, what you see is basically an area that hyperfluoresces early, and that increases in fluorescence but does not increase in size, and is not associated with any leakage, with any fuzziness around it. And this is because the fluid remains very well sequestrated into the RPE. Therefore, if you have choroidal fluid coming in under the retinal pigment epithelium, it's going to go under the RPE, but it's not going to be able to dissect and separate the remainder of the RPE from the choriocapillaries, because the remainder of the RPE is pretty much attached very firmly to the choriocapillaries. So those things will manifest as hyperfluorescences with no fuzziness around them. There will also be pooling, but pooling without fuzziness. And on OCT, you can see that the pigment epithelium is itself elevated. The fluid is serous. It's pretty much dark here, hyporeflective, and you can see the Brooks membrane right there. Clear so far? Yeah? Okay. So we talked about this. This is just to show you the pigment epithelial detachment, how it shows. You have an area of early hyperfluorescence, and this area of early hyperfluorescence remains stable in size, but it just increases in intensity. Sometimes what you have is a little bit of yellowish or whitish specks or precipitates at the back surface of the retina, such as cases like this, okay? Or what you can have is a chronic bleb that is filled with yellowish fluid because of chronicity. Because what happens is that the photoreceptors are continuously shedding their discs. Remember, we talked about that yesterday. And the discs are supposed to go into the retinal pigment epithelium. But now that there is a separation between the RPE and the retina, the discs and the material inside the disc, the fluorophores inside the disc, have nowhere to go. So they kind of accumulate at the back surface of the retina, causing these yellowishness which we know that are fluorophores, and in some cases they cause these speck-like changes. Now, the fluid can disappear, and it can leave behind it RPE damage. And the RPE damage will be presented as window effects. We're going to talk about that in 2 weeks when we talk about the fluorescein angiogram. So window defects are actually areas of hyperfluorescences of the retinal pigment epithelium that remain stable in size, but that can increase as you go on the angiogram, and then at a certain point they start to decrease in intensity, but they remain stable. So retinal pigment epithelial damage, loss of RPE pigmentation, mostly sometimes RPE atrophy, can accompany central serous, and sometimes all what you see in a patient who has had central serous are these RPE changes, nothing else. No pigment epithelial detachments, no neurosensory retinal detachment, just RPE changes. In a patient who is male, between 20 and 50, you have to kind of consider that the patient has had CSR. You can, these RPE changes can cause significant visual loss, particularly if they are next to the fovea, such as the case here. This is here just RPE changes and no leakage. And in some cases, those RPE changes are major. They basically, there is a continuous ooze of fluid from the RPE under the retina, and this fluid gravitates inferiorly, causing what we call the tracks, okay? These are signs of previous leakage. They're not pathognomonic of CSR. Tumors that leak a lot can also have this, but this is an indirect sign that tells you that you have to look for a leaky spot. Okay, and in some cases, the retinal detachment is so big that it actually resembles a retinal detachment. So you always have to consider, when you see a patient with retinal detachment, that of course you have to look for a break, and when you see a break, you have to look for another and another. But if you don't find a break, consider exudative detachment. And in the diagnosis of exudative detachment, do consider the possibility that there could be leaks, CSCR type of leaks from the RPE. How do you diagnose CSCR? Well, clinically, yes, but you will confirm it with angiography. You will use the OCT, which is a very non-invasive tool to document the presence of fluid. You can also use autofluorescence and ICG angiography. Documenting, or diagnosing CSCR, we talked about this all this time, is that you see the bleb right there. You do a fluorescein angiogram. You see the hyperfluorescent spot that increases in size. That basically also pools. You have a little bit of hyperfluorescent pooling in the late phases of angiogram. This is very typical. You can have PEDs, as we mentioned, and you can have tracks. And in some cases, just RPE changes. OCT is very helpful because it will show you the neurosensory retinal detachment. It will show you the pigment epithelial detachment. It's very non-invasive, so there's no risk for the patient. It also tells you whether this detachment is acute or chronic. In the case where it's acute, generally the back surface of the retinal, the photoreceptors is smooth and thin. And if you have chronic fluid and a lot of photoreceptor discs that are stuck to the back of the photoreceptor outer segments, you're going to have this shaggy appearance right there. Okay, and that may be associated with some RPE changes, because with time, people do get RPE changes if the neurosensory retinal detachment is too chronic. This is how you diagnose CSC, right? But this is not enough, because you can have neurosensory retinal detachment and other causes. So you need the fluorescein to actually help you out and to determine that this is indeed leakage due to focal points of leakage in the RPE. One thing that the OCT does, especially with the enhanced depth imaging OCT, people with CSR tend to have thicker choroids. So if you do an OCT with enhanced depth imaging, you'll be able to determine that the choroid is thicker than usual, and that is an extra clue that you have central serous pathology going on. Now, you can also do an autofluorescence, but this will only help generally if you have a chronic fluid. When you have a lot of stacked photoreceptors and fluorophores in the neurosensory detachment, then you have basically all those fluorophores are going to be autofluorescent. They're going to fluoresce on their own. And with special filters, you will see hyper fluorescence that can give you a clue that this is that basically tells you that there is a chronic fluid there. It doesn't really diagnose central serous, because you can see structures like this also in Best vitelliform dystrophy and in other causes of chronic detachment. But it just tells you that there is chronic fluid there. If you have indocyanine green, if you are a little bit hesitant. Are we dealing with a central serous, or are we dealing with a choroidal neovascular membrane, a tiny one that may be leaking fluid? You can do an ICG angiography, and it will show you diffuse hyperpermeability, particularly in patchy ways. It will show you sometimes these PEDs that have this hyperfluorescent rim. In general, you just have an increased permeability of the choroid that's very clearly visible in ICG, and it will help you to determine whether this is, a polypoidal vasculopathy in CNV or CSR. Most of the time, CSR is self-limited. A patient may have this detachment, and things will resolve in about 2 to 4 months. And the vision generally returns, but somehow never completely as before. Patients will continue to complain of problems with contrast sensitivity, with scotoma, sometimes with night vision. But sometimes the CSR leaves sequela, as we said. One of those sequela are these RPE changes, particularly if it's chronic, or the deposits under the retina and progressive RPE changes. Recurrence is common. So the fact that CSR has resolved does not guarantee that it will not recur again. It actually does recur a lot. And it can, as we said, CSR can not resolve. It can just continue, and in this case, you will have progressive RPE changes, progressive fibrosis, and in some cases, even choroidal neovascular membranes that develop at the site of the leak, and in some cases, as we said before, a little bit of a retinal dysfunction with the presence of a CNV. So a chronic CSR is usually correlated with poor outcome. Not every subretinal fluid means CSR. CSR has to be differentiated from inflammatory diseases such as posterior scleritis and Harada and multifocal choroiditis, from malignant hypertension, because malignant hypertension also causes focal ischemia of the choroid and therefore leakage and disruption of the RPE pump. Polypoidal vasculopathy, a subtype of AMD, which we're going to cover in 2 weeks, can also give exudative phenomena, neurosensory retinal detachments. Vitelliform macular dystrophy has to be differentiated from chronic CSR. Tumors, because a lot of tumors also, cause neurosensory retinal detachment. Optic nerve maculopathy can also create fluid egress from the pit into the macula, retinal species, and all these can have to be differentiated from CSR. Usually it's pretty easy with the presence of fluorescein and the OCT. How do you treat it, and do you treat it? Well, if it's a first episode, you may not want to treat it immediately, although now the literature is in favor of rather treating earlier and not later. We used to say classically wait for 4 months, and if in 4 months it doesn't resolve, go ahead and treat it. But actually the presence of chronic fluid under the fovea is not a good thing, so we tend to now treat a little earlier. But if it's a first episode, and you may want to wait a month or 2 to see if the fluid resolves. How do you do it? You don't need to do a fluorescein angiogram each time. You just do a baseline OCT, and then you get another OCT in a month or so and see if the fluid is becoming less. If the fluid is not decreasing, then you really should treat. And there are several ways of treating this. One way, the classic way of treating it, is just applying very, very light laser to the point that leaks. And in general, we do this when we think that the point of leakage is safe away from the foveal center. Usually 500 microns or more, preferably more. You need to barely touch it with laser, create a very subtle reaction. You don't need to burn it extensively like you would do a membrane or a macroaneurysm. And this would be recommended if the fluid doesn't resolve, or if the patient is a second episode and you're afraid that this may create more visual loss, or if the patient has a recent episode, but the patient is, for instance, a doctor or an architect and needs his vision. If the patient has CSR in the other eye that causes loss of vision, it is a good idea to go ahead and treat earlier, the contralateral eye when it develops it. And if you have a severe form, it's better to treat it. Laser is not without consequences. You can get enlargement of the scar. You can get choroidal neovascularization from the scar. So you have to counsel the patient really well. Another way of treating central serous, particularly for those spots that are close to the foveal center, is photodynamic therapy. This is reserved for central leaks, for chronic CSCR. And in general, when we do photodynamic therapy, we use a half fluence. This is basically, we inject a dye that's called Visidyne or verteporfin into the bloodstream, and about 10 seconds later, about 5 minutes after the after the injection has finished. The infusion of fluid is usually about 10 minutes, and 5 minutes later we can go ahead and expose the area that we have delineated on ICG and on FA to a light, a specific dye light that is going to activate the molecules in this dye and cause the choroidal vessels to close. So in general, we don't use the full dose of verteporfin. We use a half dose. We use low fluence, or you can use the full dose and just expose the eye to this light. Instead of 83 seconds, you can do it for like 45 seconds or so. But what happens with a lot of times that you use this PDT is that you get a choroidal atrophy, so you have to use it with caution because it can itself create a little bit of atrophy and decrease vision. Now, there is a newer modality of treatment. It's not yet FDA approved, but the minute you stop this medication, it's still under investigation. It's very important to counsel the patients, and they should know about their disease and know that it can recur. They should avoid using steroids, even low doses of steroids, and it's important to also refractant so that we can help them with the gene clear. Is this clear so far? Yeah? We're going to move on to something completely different. Anything else? Questions? No? Okay, go ahead. Yes, okay. I think the literature is tending to prove that there isn't. And I know that anti-VEGF have been used because of the hyperpermeability. The thought is that you decrease the permeability, therefore you decrease it. It may work very well in patients who have a PCV that simulates CSR, and then anti-VEGF would work, and people would think that it works. And it's very difficult to prove that anti-VEGF would work because the natural history of the central serous chorioretinopathy is also variable. Some people resolve on their own, so it's really hard to prove that it's the condition. But I think there's an article that came out in Retina last year that compared, and there was no real statistical proof, that it does help. I personally don't use anti-VEGF, but if I'm suspicious that I'm dealing with a PCV, for instance, and not a CSR, and a borderline patient with 50 years old, where the hyperfluorescent dot, or even the PED is not exactly a clear-cut serous PED, I may, in these cases, give a trial of anti-VEGF, because I don't want to be missing out on a polypoidal vasculopathy that can look like. Okay, we're going to be talking now about yes. Absolutely, yeah, that's right. So, vitreoretinal interface abnormalities. So these are now we're going to talk about pathologies that result from a problem that happened after an abnormal posterior vitreous detachment, where the vitreous did not separate itself properly or without consequence from the fovea. Okay, we saw yesterday how a posterior vitreous detachment develops, and we said that it is a very normal thing to have as people age. So it's very common to have a PVD, and usually what happens is the PVD starts at the areas where the attachment of the vitreous to the retina and the ILM are not so strong, and then it moves on to areas that are where the attachments are a little stronger, such as the fovea, the vessels, the fovea, then the optic nerve, and so forth. And when you have the vitreous completely detached from the optic nerve, this is what we call a complete PVD. Now, you can have a posterior vitreous detachment that occurs, but everywhere else, the vitreous is detached from the retina, but it's still stuck to the fovea, and that we call that a vitreomacular adhesion. And in some cases, this vitreous, it wants to pull a little further inside the eye, and if it does pull a little further on the fovea, we call that a vitreomacular traction. Here are the stages of a PVD, for those who were not there yesterday. So basically, it starts with a perifoveal detachment, and you see that along the optic nerve, the vitreous remains attached. It also remains attached at the fovea. Then the PVD kind of snaps away from the fovea, and then after that, it snaps away from everywhere else. And the last thing to go is usually the optic nerve head. the vitreous detaches from the optic nerve head. Of course, it never detaches at the level of the what? Thank you. Perfect. All right. Now, a vitreomacular adhesion is basically, therefore, vitreous detached everywhere except at the fovea. And in this case, you have no distortion of the foveal anatomy at all, and it's not really pathologic, and it's also asymptomatic. So it is not really pathologic. It's something to be watched. Now, this adhesion can be just a focal, just at the level of the fovea, the center of the fovea, or it can even be broad, including, parts of the macula and even the optic nerve head. If the focal adhesion or even the broad adhesion increases, you get what we call traction, vitreomacular traction. In this case, you get disturbances of the visual function, and you get distortion and disturbances of the retinal structures. So you can have a focal traction right there, tenting the fovea upwards. Of course, this will be symptomatic in most cases. In some cases, you will have such a traction that actually cause splitting and cavitation inside the fovea and getting cysts. If you have a broad adhesion, these cavitations are unlikely. What you get is basically a retinal thickening. Everything just moves forwards. You get a loss of the depression in the retinal thickening. You can even get retinal detachment. So just remember, vitreomacular adhesion is a term that we use when there's only adhesion of the vitreous to the fovea without abnormality in structure and asymptomatic. And traction is used is when you have symptoms and the fovea structure doesn't look anymore normal. How do you treat this? Well, if it's an adhesion, you don't treat, you just follow. If it's a traction, then, and the patient has symptoms, you may want to consider treatment. Sometimes you watch a little bit and, the vitreous lifts itself and, all is fine. In some cases, no, it doesn't, and then you need to consider doing something to lift the vitreous off the macula. And the classic way to do this is by doing a parsippany vitrectomy. That is a surgical approach. You go in with instruments, you clear the vitreous, and then you basically peel it off. And you may also peel, the internal limiting membrane with it. And in general, this has a good outcome. In some cases, and more recently, we've been talking about injecting the eye, injecting the vitreous with an enzyme. It's called ochriplasmin. And this enzyme basically is going to split the fibronectin and the laminin enzymatically, in the vitreous, and is going to hopefully split these adhesions between the posterior vitreous and the fovea, and cause, a separation, and therefore everything, the fovea comes back, snaps back into place. Now, this is not always, it doesn't always work. It has side effects. It causes dyschromatopsia. It can cause some ERD changes, and it doesn't always work. And it only works if you have focal adhesions, really, if you have small adhesions. And it's also very expensive, so it's something that you have to use with caution. Now, if the PVD doesn't occur normally, and you continue to have this vitreomacular adhesion and then traction, what can happen is that the glia of the surface of the retina, the microglia, or the Muller cell, is going to start to form membranes, okay? And you get what we call epiretinal membranes. But epiretinal membranes don't necessarily happen because of an abnormal PVD. We're going to talk about this in a moment. They also happen in other conditions, okay, such as inflammatory conditions or a traumatic condition. So what is an epiretinal membrane? It's basically a membrane on the surface of the macula. I like to call them epimacular membrane rather than epiretinal membrane because it's just more specific. And it results from basically astroglial proliferation, like proliferation from the Muller cells themselves, or even the RPE. And it's considered like a variant of a tissue response. And these are some other terms that you may hear. So retinal epimacular membranes can happen after retinal detachment, especially if you have breaks, large breaks in the retina, and those the RPE from those large breaks goes into the vitreous cavity and kind of swims around and settles on the surface of the macula and starts to create a fibrous a proliferation there. It can happen after retinopexy, either with laser or cryo, basically the same mechanism. It can happen if you have inflammation in the eye. Retinal vein occlusions and diabetic macular edema also cause this. Trauma as well, especially if you have hemorrhage settling on the surface of the retina or in the vitreous, that can lead to wound healing response and proliferation. But we're going to talk a little bit more about those idiopathic epimacular membranes that result from an abnormal PVD. So when you have a vitreomacular traction, what's going to happen is the glial cells here are going to start laying down basically collagen on the surface of the retina. And if this is a simple traction, all what's going to happen is that the glial cells are going to lay down the collagen right there, And this is not going to cause a lot of contraction, okay? Not a lot of distortion. But if you have a complicated PVD, if you have basically a lot of traction and you have, maybe I have a picture, yeah. If you have a PVD that isn't just a simple PVD and a vitreomacular, I'm sorry, if you have a PVD and you have a vitreomacular traction that isn't simple, if you start to have splits into the cortex of the vitreous itself, of the posterior vitreous, or if you have splits inside the retina, what can happen is the proliferation can occur not just on the surface of the retina, but it will occur on the surface of the retina, it will follow the posterior vitreous phase, it will go within the cortex that is split and even here, and it will cause like, you know, crumping, you know, or puckering. So simple epiretinal membranes are usually non-contractile, and they can manifest like this, what we call often a cellophane maculopathy. Complicated, complex contractile epiretinal membranes do have more than glial cells. They also have, you know, fibrocytes and RPE cells that are capable of creating, of laying down your contractile tissues, contractile fibrosis, and they would cause puckering. And when you have puckering like this, you will have not just retinal thickening, but you can also have vascular distortion. The membrane basically interferes with the normal pumping mechanisms that exist in the retina. You can have leakage. So in addition to just the distortion, you also have thickening and chronic edema. So everything, so that really the function of the retina, you know, is severely compromised, and they particularly affect vision. Okay, what are the signs of and symptoms of an epimacular membrane? Well, imagine, if you have distortion, you will have, you know, metamorphopsia, you can have micropsia, you can have scotoma even. If you do a ret-free picture, you can see the epiretinal membrane outlined really nicely. If you do a fluorescein angiogram, you see the traction, you see the distortion of the vessels, and you see the leakage, the late leakage from these distorted vessels. But really, what we use right now most of the time is just the non-invasive optical coherence tomography, which shows the epiretinal membrane as a hyperreflective tissue. It shows the distortion of the retina and, you know, all the disorganization of the retina if it exists. What happens if you leave a membrane? It will cause progressive contraction and more wrinkling, more leakage, more cystoid macular edema. The separation of epiretinal membrane is not very common. It's rather rare, okay? But not every membrane needs surgery either. So if the patient doesn't have much symptoms, or if the needs are not much, you may want to, you know, watch that initially at least to make sure that, you know, there is no progressive visual decline before deciding to do a vitrectomy. If you need to treat, and most of the time we do treat epiretinal membranes because they do cause visual problems. In this case, you cannot use ocriplasmin, right? Because ocriplasmin is just to separate the vitreous, you know, from the retina. So attention, no ocriplasmin if you have an epiretinal membrane. It will not work. So what you would do is a vitrectomy. Again, you go in with instruments and you clear the vitreous. You basically lift the posterior vitreous off the surface of the retina, and then with special forceps, you basically peel the epiretinal membrane. And most of the time, people do better. The vision, there's a visual gain, maybe by 2 or 3 lines. And the earlier you do it, the better it is. But it's a surgical procedure, nevertheless, so you could have retinal breaks, you can have retinal detachment, you can have endophthalmitis, glaucoma, and of course, after every vitrectomy, you know, within the few years that follows, usually you get nuclear sclerosis or a posterior subcapsular cataract, something you have to consider. Another pathology that happens because of vitreoretinal interface abnormalities is macular holes. And this you're going to see a lot of. So macular holes are full thickness neurosensitive retinal breaks at the level of the fovea. Most of the time they're idiopathic. They occur more often in women than in men, and usually in the patients in their 60s. Initially, Donald Goss thought that the macular hole is caused by a tangential traction, not an anteroposterior traction from the vitreous, but a tangential traction from of the premacular vitreous that is pulling sideways, okay? He thought the vitreous is stuck to the retina and it's contracting and it's pulling sideways. So if it pulls sideways, what would happen? You get 4 stages. The first stage would be this stage right there. Imagine that the vitreous is pulling sideways, and usually the fovea is like this, right? So if vitreous is pulling sideways, well, the first thing that's going to happen is that the fovea is going to elevate itself. So, okay? And therefore, all that xanthophyll that we talked about yesterday, all that pigment in the retina is going to move centrally and give what we call a yellow dot or a yellow spot. And as the traction increases sideways, this xanthophyll is going to migrate centrifugally to create what we call a ring, okay? And these cases, in both these cases, you don't have a hole in the retina yet. The fovea is not split yet, it's just stretched. And therefore we call this impending hole. This is not a hole yet, okay? Now, if the traction continues, then what happens is at one point, the fovea is going to have a little break in it, okay? And that is progression into an occult hole, according to Gauss. And why do we call it occult? Because at that time, the prefoveal cortex is still stuck. So basically, you have a break in the fovea, but the vitreous in front of the fovea, stuck to the fovea, is still intact. And what Gauss said is that if you have a separation of the vitreous, these holes will kind of close, and end of story. But if the traction continues, you may end up with a manifest hole, a stage 2 hole, which is now a full thickness hole that is visible, but it's kind of a tiny hole. So this hole can happen either because the precortical vitreous lifts, but you still have traction, and therefore the hole becomes bigger, or the precortical cortex has the premacular vitreous cortex gets a rent in it, okay, and then the traction continues, and it also pulls the fovea with it in a kind of a can opener technique. So you get a full. This is another mechanism of getting a full thickness macular hole. As the traction continues, you would get bigger holes. At this point, we call them a stage 3 hole. And a stage 3 hole is basically a full thickness hole in which the prefoveal cortex is still kind of sitting in front of it, but you now see the hole very clearly. And a stage 4 hole is when the prefoveal cortex is completely separated, and you have a separation of the vitreous from the optic nerve. Now, this is the theory of Gauss. Now, we know that there was a lot of truth in it, but it is not just tangential traction. By OCT and by ultrasound, we know now that the anterior vitreomacular traction plays a role. So in incomplete PVD, the ones that we talked about earlier, the vitreomacular adhesion, the vitreomacular traction, yes, traction, vitreomacular traction, in an anteroposterior direction can create a macular hole. We've seen this on OCT very clearly. What you get first is a cavitation, which we talked about. So you have a kind of a pseudocyst, and if the traction continues, in an anteroposterior direction, you get a rent, you get a split into the retina. And now if you imagine that you have a split in the retina that continues all the way down, this is now a full thickness hole, even if you don't see it very clearly and the vitreous is still kind of stuck to it. But as the vitreous continues to pull, now you see basically an operculum, and you see a full thickness rent, all the way to the photoreceptors. And if this lifts completely, then you have a bigger hole that has the tendency to stretch. Clear? Yeah? Silence. If it's not clear, let me know, because it's important that you understand the mechanism here. So here again, just to tell you that you've got a cyst, cavitation, and then you've got an unroofing because the vitreous continues to pull, and then it pulls even further, and you get a big hole. And here is a beautiful article that appeared in Ophthalmology, which was the first to actually document this, showing the same thing. Here you have just the vitreomacular early traction. It's not really an adhesion because you have cystic changes, but you see the vitreous is adherent. And here the vitreous pulls further. Now you can see cystic changes and a kind of a pillar here, that tissue that is still solid and trying to not to break, but eventually what it does break. Okay, and now you have basically a very thin roof right there, and continuous traction until this breaks right there. See that? It breaks here, and you have a full thickness break. Now, if you have a small break, like a stage 1 or a very small stage 2 hole, it can repair itself. If the vitreous detaches and you have a very tiny hole, it is possible for the glial tissues to cause closure. But more commonly, you get enlargement. And what happens is that the glial cells will actually proliferate here and here, basically on the edges of the macular hole, and they cause this eversion of the hole. And oftentimes you have subretinal fluid in this. So the glial cells are going to contract and keep the hole open. And this is why ILM peeling, the results when you do a macular hole surgery with vitrectomy, the results with ILM peeling are better because you actually get rid of these glial cell proliferation that are contributing to that create the ILM and that contribute to the maintenance of an open hole. What are the symptoms of a hole? Well, most of the time it's an incidental discovery of a patient who just incidentally discovers that he or she doesn't see well. Generally, when the vision loss occurs, it stabilizes over time. So people don't get progressive visual loss, forever. No, So on a fundus examination, you see this round excavation. You have oftentimes a subretinal fluid rim, a cuff right there. You can often see RPE changes at the base of the hole, and in some cases you see an epiretinal membrane, and in some cases you see an operculum. Before we had OCT, we were heroes. We used to diagnose macular holes based on clinical examination and based also on something called the Watzke-Allen test, is that we would put a very thin slit lamp beam at the hole itself and ask the patient if he would see a complete beam of light, or if there is a scotoma, or if the light was abruptly cut in the middle. And that would be called a positive Watzke-Allen sign. We used to sometimes bring the patient to the laser room and not put laser, but just put a very tiny aiming beam in the center of the hole and see if the patient sees it. And if the patient does not see it, then that would really indicate that there is a full thickness hole. We don't do these things anymore. We now rely on OCT. On a fluorescein angiogram, oftentimes because you have RPE changes, you can see hyperfluorescence in the center. This is also because you have loss of the xanthophyll, so things will be a little bit more hyperfluorescent centrally. The subretinal fluid rim will cause a little bit of a hypofluorescence by blockage. But now, as we said, the OCT is the gold standard. It shows you the full thickness hole going all the way from the ILM all the way to the retinal pigment epithelium, which is intact, but the photoreceptors are no longer there. And it will show you the vitreomacular interface relationships. And will show you an operculum if there is one. And it will make the differential diagnosis if you have like a partial thickness macular hole, which can look clinically like a hole. In this case, if you have an inner lamellar hole, okay, this happens by the same mechanism as the anteroposterior traction, except that you get a rent in the fovea, in the fovea, but just in the inner part of the retina, and that does not involve the photoreceptors. And in this case, you can, it looks like a macular hole, but you do an OCT and you find that the photoreceptor layer, the outer nuclear layer, is intact. And in this case, you don't have any subretinal fluid, and basically this does not usually progress to a full thickness hole. The OCT can tell you if it's a lamellar macular hole that is an outer hole, and the mechanism here is completely different. Usually this happens if you have a commotio retinae or if you have a light injury that affects the photoreceptors. You get disruption of the photoreceptors. In this case, you have basically a loss of tissue of the outer retina and a thin inner retina, which, if it unroofs, can create a full thickness macular hole. And the OCT will help differentiate what we say when you have something that may look like a hole but is not a hole if you have a pseudomacular hole. That is, if you have an intact retina, but you have an epiretinal membrane with a rent, with a discontinuation in the middle here. It may look like a hole clinically, but when you do an OCT, you just often see just the epiretinal membrane is discontinued and the fovea is intact, although maybe kind of steep. If you just have RPE changes, in some cases of atrophy, it may look like a hole, but it is not a hole, just RPE change. In some dystrophies, this can happen. Or if you have a juxtafoveal telangiectasia, that sometimes simulates a hole. Forget this. So it's important to know that people who tend to have a macular hole in one eye are likely to get it in the other eye, not always. But if you have one macular hole in one eye and no PVD, no complete PVD, and the other eye still doesn't have a PVD, those are the patients at the highest risk. There are other causes of macular holes rather than just vitreomacular interface abnormality. Trauma is one, pathologic myopia, laser, and even blue laser injuries, which you're going to see if we have time in a moment, and many others. Traumatic macular holes tend to be accompanied by much more signs of trauma, like choroidal ruptures or commotio retinae or retinal pigment epithelial changes. They tend to be larger than usual. They can occur either because you have dissolution of the retinal tissue or because you have just acute PVD and anteroposterior traction and a little operculum going into a little operculum of the fovea going into the vitreous, or sometimes you have a prolonged cystoid macular edema, and that kind of unroofs and gives you a macular hole. In pathologic myopia, they're very common, macular holes, very, very common, and they can lead to retinal detachment in this case. They're more difficult to see, so OCT is really, really helpful in these cases. You can get macular holes following laser, following any kind of trauma, and as we said, after photic injury. How do we treat a macular hole? Very, very quickly, I'm not going to go into the details because we have a lot to cover, is that if you have an impending macular hole, a macular hole that has not yet become a full thickness macular hole, you don't treat that, okay? People have tried ocriplasmin, but I don't think really it's indicated. I think these things have to be watched. If they become full thickness holes, then it is possible, because a lot of these will abort. More than half will abort by themselves, so there's no need to go ahead and intervene. If you do have a macular hole, even a tiny stage 2 macular hole, that is the perfect indication to go ahead and do surgery. So what we do is we enter the eye, again, we remove the vitreous, the cortical vitreous, we peel we remove the core vitreous, and then we peel the cortical vitreous from the surface of the optic nerve head and the surface of the macula entirely. We may use triamcinolone to make sure that we peeled all the cortex, and then we basically, we prefer to do an ILM peeling with forceps, and then we inject gas, okay, inside the eye. And now the debate is whether you need to do a prone positioning, keep the patient face down for a few days or not. That is under debate. Some people are saying that you don't need to do that anymore, that just, putting gas or even air is enough to be followed. The results of surgical treatment are generally good, okay? With people who have experience, there's a 90% closure rate. If it doesn't close, the holes will remain open, of course, and they may enlarge, okay? But of course, again, this is surgery, so people have to be counseled properly. You can have RPE alterations centrally at the macula. You can have visual field loss. This happens a lot, actually. Nuclear sclerosis is a complication, and then all the complications of intraretinal surgery, intraocular surgery, that retinal detachments, vitreous hemorrhages, glaucoma, cataract, what have you. Ocriplasmin can be used in these cases. You separate the vitreous with the hope that the fovea hole will come down and will close. Usually it's limited to small holes. It is expensive, and it has a lot of complications, and the success rate are not as high. They're not 90%. They're not as high as with surgery. So really, it should be limited only to patients who cannot tolerate surgery, or if you think that surgery is not a good idea in those patients. But you have to remember that counseling is important, selection is important, and it's expensive. I think it costs 17,000 riyals. Is it something like that? Is it 17,000 per injection? It costs as much as a vitrectomy, basically. Post-surgical macular edema. I'm going to go quickly here. Macular edema can happen in a lot of cases, okay? But we're going to be talking only about the ones that happen after cataract surgery or, other anterior segment surgery. And we call that the Irvine-Goss syndrome. And it's a very common cause for unexpected poorer vision after surgery. Patient initially gets cataract surgery, is very happy. A few weeks later, the vision isn't as good, and you see leakage. You see a cystoid macular edema clinically, and when you do a fluorescein angiogram, you see leakage and pooling of fluid at the level of the fovea, in addition to some hyperfluorescence of the RPE, of the optic nerve, okay? And we don't still know exactly what causes this, but we know that it's associated with the hyperpermeability of these perifoveal retinal capillaries. And if you do an OCT, you can clearly see the cystic changes at the level of the fovea. The pockets of fluid are usually inside the plexiform layers, the inner and the outer plexiform layers. The fluorescein angiogram is diagnostic because not only it will show you the perifoveal hyperfluorescence and the pooling, the very characteristic pooling of fluid inside the plexiform layer, and so giving you this petaloid appearance. But also the optic nerve is usually hyperfluorescent, and that distinguishes this kind of edema from other types of edema, such as diabetic maculopathy or other edemas. Usually, post-surgical CME is self-limited, but sometimes it can really linger on, and if it does, then you may get chronic cystoid changes, degenerative changes, and lamellar hole formation. How do you treat it? Well, the first step in treating a post-surgical CME is really to see why did it happen. And more often than not, people forget to look clearly and very, carefully at the anterior segment, looking for vitreous strands or a kind of a misplaced IOL or an IOL that keeps on rubbing against the iris or basically a reason for continued inflammation in the eye. So the first thing to do is, if you have any of these signs, if you have a vitreous that is coming into the anterior chamber, that needs to be cleared. Okay, if you have iris chaffing or misplaced IOL, you probably should consider doing something there before giving the patient just medicine. But if the patient doesn't have any of this, then topical steroids initially and non-steroidal inflammatory drops are helpful. If that doesn't work, you can go ahead and give juxta-ocular subtenon injections of steroids. Diamox has been tried and may work. Okay, intravitreal steroids does work, but in general, the macular edema recurs, and it recurs more violently, so I wouldn't recommend it. And if nothing works, then yes, you can go ahead and do a vitrectomy, clear the vitreous from the cytokines, and actually take a very, very good look at the ciliary body, because sometimes the IOL seems to be located in a very nice position, but when you do a proper exam, you can see maybe that one of the haptics is rubbing against the ciliary body in an abnormal way, causing this continuous edema. All right, juxtafoveal telangiectasia. I may not have time to go over the entire thing here, but this is an article that I wrote a few years ago. It's a review article, and it's in Meajo, in the 2010 edition of the Middle Eastern Journal of Ophthalmology, and it's a review of the entire thing. So idiopathic juxtafoveolar retinal telangiectasis has been, this is the name that Dr. Donald Goss gave, but other people have called it differently, but it's basically the same thing. Some people have called it parafoveal telangiectasia or idiopathic macular telangiectasia. What it means is you have an alterations of the capillary network around the fovea, either basically incompetence or dilations or ectasia, and it can happen in one or both eyes. And there are three groups based on biomicroscopy and fluorescein angiography. The first group is the unilateral visible telangiectasia. The second group is the bilateral occult telangiectasia. And the third group is a very rare one. I only have one case over 25 years. It's the occlusive telangiectasia. That means where capillaries around the fovea start to occlude, okay? So the first type is the unilateral aneurysmal, exudative, visible telangiectasia in one eye. And usually it happens in males, and the mean age is around 40 years. People will complain of visual blur, and the vision is usually around 20/40. And what you see are visible telangiectasia around at the temporal part of the most of the time they're at the temporal part of the fovea. And they're associated, because they are exuding, okay, they're aneurysmal, they are associated with macular edema and with lipid, okay? So here it is, you do a fluorescein angiogram, it's very clear, you see them clinically as well, if you're careful, and you have these aneurysmal dilations next to the fovea, and these aneurysmal dilations and the telangiectasia leak. You can see that there's hyperfluorescence in the late phases of the angiogram with leakage, with fuzziness, okay? You can have a little bit of non-perfusion with it. If you do an OCT, you have macular edema that you cannot distinguish from other types of macular edema, okay? And basically, so here to sum it up is these telangiectasia look exactly like the telangiectasis you see in Coates disease, but they are limited to the parafoveal region. They are not widespread into the retina. The cause of visual loss in these cases is macular edema, is the exudation, okay? And the vision can be very, very good for many, many years, but it will deteriorate if the edema persists for a very long time, so it is indicated to treat it. What are the differential diagnoses of this type of telangiectasis? Well, anything that can give something similar, which is like diabetic retinopathy. You can have microaneurysms and telangiectasia next to the fovea, right? Branch retinal vein occlusion, sickle cell retinopathy, because it often has these comma-shaped capillaries next to the fovea. Radiation retinopathy, a lot of things can look like that, okay? How do you treat it? Well, Goss said, at the time, there was nothing else to do except laser. So he said, okay, we can go ahead and laser this, but you have to laser this very, very carefully because so that you don't get scar enlargement into the fovea. But people have tried other things like intravitreal injections of steroids and also anti-VEGF agents. And the steroids, not so sure they work, but the anti-VEGF agents do seem to work. Okay, so I'm not going to go very far in here. The second group, which is a much more common type of telangiectasia, which is a bilateral telangiectasis, in which the telangiectasia is not necessarily very visible clinically. So you have to know about the disease in order to diagnose it. Now we call it either perifoveal telangiectasia, or we call it nowadays MACTEL for much easier. Now this is the most common. It is not congenital. It usually happens in people who are a little bit middle-aged, so a little older, males as much as females, and it's bilateral, and they have this telangiectasis happens in 5 stages, okay? First of all, you have a barely visible telangiectasis, then you start to have a little bit of foveal graying, and then you have the vessels, the veins in the retina will start to migrate and have a right-angled course and proliferate inside the retina itself deeper. This is going to be associated with retinal pigment epithelial hyperplasia because the RPE is going to come into the retina and try to eat and clean up, all the proliferation of vessels that happens there. And in some cases, this becomes wild and causing a subretinal vascularization. So the first stage is an asymptomatic stage. These are barely visible telangiectasis. Notice here that you can hardly see it. If you do a fluorescein angiogram, all what you see is a little bit of grayishness, usually on the temporal part of the fovea, okay? But you don't see capillary dilation, you just see staining. And here's the other eye of this patient with very early. And all what you see, if you're astute, if you've seen it, if you know what you're looking for, you will notice that there is a little bit of grayishness right there. Now, in stage 2, you start to have some disturbances of vision, such as metamorphopsia and maybe some paracentral scotomas. People will start saying that I'm not reading as clearly as before. And then the perifoveal graying becomes a little bit more obvious. And the foveal center is thin. So this is why sometimes people think that this could be a macular hole, but there is no macular hole. You do a fluorescein angiogram, you will see the same kind of abnormal, hyper-discrete fluorescence that you see around the fovea, and then with staining around the fovea. Now, at stage 3, you have the capillaries are going to become a little bit more apparent, and they will invade this the photoreceptor layer. This is where people are really symptomatic. You will have juxtafoveal swelling, and this is where you have the right-angled veins coming in and proliferating into the deep retinal tissues. You can have retinal crystals at the surface of the retina associated with this. And if you do a stereoangiogram, you will see that there's no pooling of the fluid, just again staining. Okay, so you will see the network a little bit clearer than before, and with staining right there, some fuzziness. The stage 4 is when the retinal pigment epithelium starts to migrate inside the retina and cause these blackish plaques. And along just under the right angle venules, as a mean of clearing it up a little bit. So basically, here's a patient of mine who I showed you pictures of, and I've been seeing her for like practically 20 years. I noticed that how she was in the left eye, she just had the grayishness here. With time, she developed this little plaque. The plaque did increase, and this is her other eye. You can see crystals in the other eye, a right-angled venule, lots of plaques, and here again, more and more plaques and more atrophy in the center. And this is how she is, how she was about a few years ago. And this is her fluorescein angiogram that shows the telangiectasia and the leakage. And this is her other eye. This is her plaque right there, hyperfluorescent, and the leakage. Crystals are very common. Sometimes all what you see are the hyperpigmented plaques with no signs of telangiectasia. This can also happen in cases that abort themselves. I'm going to close right here telling you that after a while, these telangiectasia can grow from inside the retina towards the surface under the retina, and proliferate under the retina, causing subretinal neovascularization, not choroidal, but subretinal neovascularization. And in this case, you will start to have hemorrhages, leakage, fluid, and swelling. This is one of those cases of mine in which you can see the telangiectasia very, very clearly here, but here notice that this is a different pattern altogether. This area here has much more intense leakage than the rest, and this is because it developed a subretinal neovascularization. Same thing here, and in certain cases you will get these anastomosis. The vessels are going to start to anastomose with the choroid, giving you anastomotic. What you need to know, and this will be my last slide here, is that you will have, in this type of telangiectasia, there are no aneurysms, there is no hemorrhage, and there is no CME, no swelling, no ischemia, and the visual loss is primarily due because of progressive retinal atrophy, but not because of edema. All right? I'm going to have to give the stage to Dr. Patrick, who's going to give you the grand rounds lecture. If we have time after the subretinal, after one of those basic science courses, I can finish with the juxtafoveal telangiectasia for you. Thank you very, very much.